All right, Devin, I think I see at least a majority of the committee or the board, so I'm going to go ahead and get started. As a reminder to everyone, these meetings are recorded. So you should have seen that when you joined, but if not, I'm reminding you now that participation is recorded for purposes of minutes, and we post these on our Pennie website. And additionally, please remember to mute your line if you are not speaking. It limits feedback and makes sure that we can best hear the person that is speaking. We try and do this poorly all the time, but please identify yourself and your organization before you speak. I also often forget to do that, but again, that also really helps minutes purposes because it's hard to necessarily identify people when you go back and listen to just a recording. If you're on the phone and logged in via web, if you could turn off your computer speakers, that would be great. And the polling is reserved for board members. So with all that said, at 12:02, I will call it to order, and I will start with a roll call. Cheryl Kashuba.
I'm here. Good afternoon.
Cheryl is here. I believe Megan Barber on behalf of Secretary Bogan.
Good afternoon.
Good afternoon. Frank Fernandez. I think I saw Frank.
Yeah, I'm here. Good morning.
There he is.
Afternoon, sorry.
Antoinette Kraus.
Here. Hi.
Very good. Amy Lowenstein.
I'm here. Hello.
Very good. Alexis Miller.
I'm here.
Dr. Conti, I know, is not here. She has proxies both with Cheryl Kashuba and then has also separately expressed her opinion on a couple discussion points. Carl Feldman on behalf of Secretary Arkush.
Hi, good afternoon.
Colleen Kavanaugh.
Good afternoon. I am present.
Saw you. Yep, there you are. Tia, I think I saw Tia's name.
I am here.
Very good. Okay, then we would have everyone present and accounted for. We will first start with approval of the minutes. These were distributed with all of the board materials. Looking for a motion to adopt the minutes of our February 22nd meeting of the board.
This is Antoinette. I'll make the motion.
Antoinette moves. Do we have a second?
I'll second. This is Amy.
Amy seconds. Any discussion? Hearing none. All in favor say aye.
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 Any opposed? Hearing none, motion carries unanimously. The minutes are approved of our February 22nd meeting. At this point, I'd like to break for public participation. So as you know, public comment is permitted at the meetings as required by the Sunshine Act, but to ensure the orderly progress, we ask that all comments be directed to the chair and be limited to no more than 3 minutes. Questions asked of the chair or the board may or may not be addressed during the meeting. With that, I will open it up to see if there's any questions, and if you could use the raise hand feature, that would be great. Seeing no hands and no one coming off mute, we will move right along. Devin, ask you to briefly introduce the board meeting.
Great. Hello, everyone. We have a few important topics today that we'll be covering. But before we jump into all of those, just wanted to provide a quick overview of where we are at this point. So since our last meeting in February, we've continued business as usual, but also keeping our eye on a few key things. The unwinding efforts do continue. In working with our counterparts at Department of Human Services, the unwinding activities on their end will extend through the end of June. So we have aligned our unwinding special enrollment period and the related activities to that end date. And after that point, we will continue with the account transfers between Medicaid and Pennie in sort of a business as usual perspective. As you may recall, it's not business as usual for us because when we started, it was in the pandemic. And so we've had the public health emergency, Medicaid, continuous coverage requirements since then. But we do feel confident from all of the lessons learned from the unwinding, the outreach we've done, and all of the streamlined processes we've put in place that we'll be able to continue those in sort of a business as usual ongoing transfer of account applications between Medicaid and Pennie. With the continued enrollment from the unwinding, we are at over 75,000 individuals who have at some point enrolled after being found ineligible for Medicaid. And we have more details on the unwinding population in the appendix. So we're not planning to go through those in detail, but just wanted to call your attention to that. And we are continuing to, again, look at those opportunities to finish strong with that population as that comes to an end. So that's the overall update. We are still, because of the additional enrollment, sitting at around 434,000 enrollees. So we're looking at a pretty stable number as we are outside of open enrollment. So with that, we will jump into the agenda. We have the strategic goals up here just as a reminder. Those were from the February meeting. But with that, we will jump into our agenda. And I'll turn it back to you, Commissioner.
Thanks, Devin. Before we move on, any questions for Devin on just the quick overview that we had? Seeing none, we will move right along into the discussion about the affordability program and looking at the various options that we have before us. I think the idea here, and as the governor's legislation continues to move, is to get a sense of the board on which methodology we would pursue, plan to do it on just ideally a consensus basis as we move through this discussion, but really that will help, I think, inform the discussion with the legislature. We've been asked a number of times, a number of people that would be impacted through different opportunities available through an affordability program. So we wanted to be able to at least kind of provide some feedback and start to tailor some of that feedback around where the sense of the board would be, which I think there's some general consensus, but want to have the conversation here to allow both that process to continue and obviously for Devin and the Pennie team to be prepared and to be thinking about what those next steps are from a groundwork perspective, with the idea that we will not vote until we have a emergency board meeting that we will schedule probably around mid-February, or I'm sorry, mid-July. There's a deadline in mid to late July at which I think Pennie has to give any notice to insurers on any changes to 834s that they need to give you 90 days notice. So I think that backs it up into July. So the goal will be to have our emergency meeting and take a final vote on how to move forward ahead of that deadline, obviously. So we'll be looking at July. At that point, we'll know whether there's a discussion to be had, whether a funding program is provided as part of the governor's budget through the legislative process, and then at which point we could decide to green light or red light the proposal that would be ideally moving forward. So today, I think we just want to talk about the options and then just generally rally around kind of the thought process for where we would go. So with that, Devin, I will turn it over to you to talk us through the different modeling that we've had done.
Great, thank you. So wanted to start off with just from the top, providing context for the affordability program and the overarching goals here of what an affordability program could help with in Pennsylvania. So generally, just working towards the goal that individuals and the healthcare system benefit economically when the insured rate is higher. For individuals, this means that if they have unexpected medical needs or emergencies, that they have coverage, which provides financial protection and can avoid medical debt or having to spend down all the savings to pay for a medical emergency that was unexpected. On the healthcare system, having a higher insured rate means better, faster reimbursements and the ability of the healthcare system to manage the care for individuals before it gets to an emergency level. So, across the board, there's just a lot of benefits the higher we can have that insured rate. Currently, Pennsylvania sits at about a 5.6% uninsured rate. That number, potentially could be higher because of the recent changes in Medicaid with the unwinding. While we have seen a lot of people come and enroll through Pennie, we know that some people who have recently been found ineligible for Medicaid have not enrolled through Pennie. Through surveys and other means, we do believe some portion of that population is uninsured. So the main two ways to decrease the uninsured rate are awareness and affordability, and they really work hand in hand. And we actually will talk about awareness and especially in the terms of assisters and what we're doing in area later on in the meeting. But on the affordability piece, they're really hand in hand. You can increase awareness, but if people come to Pennie and they fill out the application or fill out the 5 questions to see what they can afford, if they aren't seeing affordable products, then the awareness isn't really making any progress towards that uninsured rate. There really needs to be that awareness, but also when people come to Pennie, the ability to see plans that they can afford and give themselves that financial protection. So this piece is really talking about the affordability component. Next slide. So what we've heard consistently are that costs are the main barrier to enrolling and in maintaining coverage. While many people are receiving federal financial help, for some, especially at the lowest incomes, it is not enough to exceed those affordability barriers that we still hear about from consumers. In a study result from FAN that they conducted across a variety of Pennsylvanians, 4 in 10 who were eligible did not purchase due to cost. 4 in 10 who had dropped coverage at some point due to cost. And 6 in 10 who are currently enrolled through Pennie say the plans are barely affordable or unaffordable, even though they're enrolled. So they're really on the cusp of that affordability. With unaffordable options, the downsides are that individuals either go insured, which then puts them at that risk, financial risk in the case of illness or injury. It also adds to uncompensated care and medical debt, and again, not having the ability to address medical issues as they come up before they become emergencies. Individuals sometimes also enroll in unregulated plans that have lower premiums, but often exclude important medical care, have pre-existing condition exclusions, and impose lifetime or annual limits. All of those practices are prohibited under ACA compliant plans available through Pennie, and they can have the same impact as going uninsured in terms of ending up with financial implications, medical debt, or uncompensated care. Another aspect that we hear from people who have coverage is that they forego critical care because they're worried about the cost barriers to receiving care. And that really comes into the out-of-pocket costs area. So it's really, as we'll talk more, a story of sort of 2 affordability thresholds. One is that initial premium that people have to buy coverage. Then once people have coverage, it's the out-of-pocket costs that can cause them to forego or delay or not seek care when it really would be most beneficial for them to do so. And so the proposal we'll talk through really does aim to address both of those affordability components. So on the next slide, Pennsylvania is not alone in seeing these cost barriers. And as a state-based marketplace versus being on the federal platform, affordability measures are an important tool that we have as a state-based marketplace to address the needs of our population. And a majority of state marketplaces have taken steps to further reduce costs. So those are listed here, from straight premium reductions to premium and specific cost sharing reductions to a young adult subsidy, and then other affordability programs, including basic health plans and Medicaid expansions and some of the other state-based marketplaces. So we would be seeking to join this majority of state-based marketplaces that have taken action to address these cost barriers to improve the access for their populations. So on the next slide, we talk through what we did and how we approached it. So we looked at options analyzing an affordability program that would directly reduce health plan premiums. Again, we did our own internal surveys as well, in addition to FAN survey, and we did find that people who applied to Pennie and were eligible for financial help, for about half didn't enroll, and 2/3 of those cited cost as the main reason, with the majority indicating that premium was specifically too high. However, as a very close second to that were concerns around out-of-pocket costs. So we do really see this sort of pairing up of concerns around not just the premium, but concerns around deductibles and out-of-pocket costs as well. So the reason we focus on a premium subsidy is because it can have a dual impact of addressing both of those concerns. It can encourage currently uninsured individuals to enroll in coverage because it lowers that initial barrier of premium costs. For people who are already enrolled, it can allow them to buy up to a higher level of coverage that will lower their out-of-pocket costs. So in that sense, serving as an indirect cost-sharing benefit. And we'll get into the details of the models and what all of this means as we go through. So we looked at 3 options, and really the options we looked at were aimed at the model that would have the maximum consumer benefit for the amount of money that we would think we would have for a state subsidy program. The two main ones that we looked at were both income-based, because we know that people at the lower incomes who make a little too much for Medicaid are still the most uninsured group as far as income in Pennsylvania. And also at those levels, there is a fairly large federal subsidy, so it doesn't take a significant state subsidy to make a difference. So with a relatively small amount per month, you can really tip over that affordability threshold for individuals and increase access. I'm sort of building off of the foundational federal subsidies. So the two variations of that are a flat dollar model where everyone gets the same amount. So that, for example, would be $30 a month. So if you're one person, that's $30. If you're a family of four, that's $120. And the other variation of that would be a sliding scale model, where each family would get a different amount of state subsidy, but the consistent measure would be what portion of their household income they are paying towards their premium. And that's really following along and parallels how the federal subsidy is structured. So for example, someone at 200% of the federal poverty level with federal subsidies today is capped at 2% of their income paying towards their premium. Under our model, that would be brought down to 0. So that's how that structure would work. And because of the nuances of how these different models apply and stretch the dollars, it does have a different impact on the expected population, which we'll talk through in a minute. We also did look at a young adult flat dollar model. We have heard interest in this at various times, so we just wanted to model it to see what that option would look like for Pennsylvania. So we'll talk through that as well and have it throughout the deck. It would be focused on 18 to 35, which means a much smaller population. And that population for young adults does tend to be more uninsured than other age cohorts. So that was sort of why that population was looked at as well. On the next slide, we talk through one other variation that we looked at, which is whether or not to include or exclude bronze plans. So bronze plans today, especially with the federal subsidies, are fairly highly subsidized. Many people, actually most people in the incomes we're looking at have access to a free bronze plan. The challenge of bronze plans, especially at these income levels, is that they can have very high out-of-pocket costs, including deductibles in the range of $8,000 to $9,000. And when you look at some of the incomes in this range, that can be up to a third or higher of their income is in a deductible. So the concern with including bronze is that, we would be subsidizing something that is already fairly subsidized and free or nearly free for most of the population we're looking at, but also that making that more available doesn't really address the concern that we hear from consumers about the out-of-pocket costs as being a barrier. So as we'll see, we have the variations of these options throughout, but generally, we think that excluding bronze would incentivize enrollment in plans with richer benefits, which would reduce cost barriers to care. So that means increasing access to doctors, prescription drugs, and other critical medical care, and really making the plans more usable. So when we have a fixed budget that we're looking at, this really comes into play of how to stretch the dollars the most to get the most benefit for the population, looking at these different concerns that we've heard. So just setting that up to keep in mind as we go through. And if with these options, if the subsidy excludes bronze, individuals would have access to it if they select a silver or gold plan. Anyone who is currently in a bronze plan would need to change plans to silver or gold in order to receive the subsidy. Next slide. So this slide looks at exactly what these models would do. So you can see the two flat rate options with bronze and without bronze, and that's proposed to go between 151 and 250% federal poverty level at $30 or $35 a month. And you can see how excluding bronze does allow us to concentrate the funding a bit more. And so it does provide an additional benefit because it is sort of more concentrated on the silver and gold levels of coverage. Just skipping to the bottom of that chart, young adult, because this is the much smaller population that's impacted, and we'll get into those numbers in a minute, does allow us to go higher up the FPL range and provide a higher number of per member per month at a higher subsidy amount for that population because it's a much smaller population. So the sliding scale one is not, again, it's not a single same amount for everyone. It really depends on income. So what the charts below show, the orange line is what the current federal subsidies are. So you can see, for example, at 200% of your income on the orange line, you're capped at paying 2% of your income towards premium. The blue line represents what it would be with the state subsidy. So at 200%, that's brought down to 0. At 250, with including bronze, that's brought down to about 3%. And once you get closer to 300%, it starts to marry back up with the federal line. And so as you get closer, there's really sort of marginal benefit as people get closer to 300% federal poverty level. The most benefit is between 150 and 250 with some marginal benefit for the folks slightly above 250. You can see a similar effect to the flat rate one by excluding bronze, and that you're able to provide more subsidy, particularly between 200 and 250% of the federal poverty level by dropping that cap from 3.1 to 2.7. And what's really important about that is that the ability to drop and concentrate the subsidy on premiums does have an impact on the uninsured. What the modeling shows is that the uninsured are very price sensitive. So the more that you can decrease that silver premium, the more gains we would have in having people who are currently uninsured today, which tend to be a difficult population to enroll, to attract them into enroll through Pennie. So that's the details of what the programs would look like. Now we're going to focus on what the impact they would actually have. On the next slide, please. So what we looked at is what new enrollees would come in from the uninsured. Again, that's a difficult population to attract. What the current enrollees eligible for additional savings, what population that would be. And that's really the population that would have the most buy-up potential to get lower out-of-pocket costs by being able to get a higher level of coverage. The cost per person per month, and anticipated improvement to the risk pool through reduced morbidity, improved access to $0 silver plans, and the ability to buy up. So we're going to go through all of those pieces over the following slides. So the next slide is a summary of comparing all of the metrics. So you can see this, and we have bolded the sliding scale premium percentage without bronze, because that is the one that we're recommending from a Pennie perspective. So you can see that it does, that one has some of the highest forecasted new enrollees, except for the young adult subsidy. But then comparing it to the next column is the current eligible enrollees, and then the total eligible. So you can see how, in general, the sliding scale model does yield higher benefits than the flat rate one, for example. So between the two of those, the difference between the total eligible population is really on that the subsidy would not immediately go to everyone who's currently enrolled in bronze. But those bronze enrollees could buy up with a premium subsidy. So we would expect that 180 bolded there on the total eligible column to actually be quite higher, closer to 200,000, because we would expect that bronze enrollees would buy up to silver or gold level with a premium subsidy. And I think we think that would need to be paired with kind of targeted outreach and explanation and communications to that population. So in the per member per month population, and that would be about $18. And just a note about why the PMPM is different from what is offered. So for example, in that first row, if you recall from the other slide, what was offered was $30, but this is $18 for the actual PMPM. It's because people don't always use all of their state subsidy. So for example, if they were in a plan and they want to stay in that plan and it's $15, they would only use half of their state subsidy, for example. So that's sort of why those numbers look different. I think a really important point about the PMPM number is related to budget sustainability. When we get new enrollees in, which is what we would hope would happen with a state subsidy, and that there would potentially be momentum of even exceeding some of these new enrollee numbers from word of mouth and other ways that we know people sort of hear about more affordable coverage. The key point here is that every person we get in, the user fee is about $19 per member per month. So if we had a state subsidy that was below that, we would be able to continue to fund a state subsidy even with growth in enrollment within our current user fee structure. Right now, our user fee goes to operational costs and reinsurance, but under the proposal, reinsurance would be otherwise funded. Our operating costs, we don't anticipate a lot of changes there, and those are already fully covered by the enrollment base we have now. So that means any additional enrollee that comes in, we'd be able to fully apply that user fee to the state subsidy program, making the subsidy program self-sustaining, even with enrollment growth that exceeds these numbers here. So I just wanted to make that point because I think it's a really important part around the sustainability of the state subsidy program. Because if we are successful, we will get even more numbers than this, and we want to make sure, and we think this bears out, that we will be able to support that from a budget perspective on an ongoing basis. The last column looks at the risk pool morbidity, and these are decreases to morbidity, so this would be an improvement to the individual market, and the sliding scale premium percentage one does have the highest anticipated impact there. So I'll pause here just to see if there's any other questions on this slide and the comparison between these models.
Seeing no questions, keep going, Devin.
Sorry. Oh, Sorry.
Oh, Colleen had a question.
Well, hit two buttons. So I think, just some of the conversation, I know what you went through here, and I can understand the logic you're presenting as far as the including or excluding bronze. And I guess just the ability to potentially help another 40,000 people with lower premiums is also, I don't know if I'm doing my math right. I do. Okay. Like it's, I guess, about almost 45,000 people. That's just the one thing I just wanted to make sure that we had conversation around, that we're all comfortable with, supporting a smaller number of people, but with the thought that that would allow them to purchase more affordable plans. I just wanted to have that conversation. I don't know if anybody else had any comments or feedback on that, but thought that was worth at least having the conversation.
Yeah, I think Alexis might have a thought. Go ahead, Alexis.
Yeah, I think, I wonder if Devin, it would be helpful to walk through any of the assumptions that got to the forecasted new enrollees. Because I think that's those are kind of the assumptions that matter most. So to Colleen's point, if we could address another 40,000, that would be great. Just, I think we need to understand what rationale would apply to say, yeah, but even if we do get another 40,000 in the addressable universe, we think we're actually going to enroll less.
So I think it's a trade-off. It becomes a trade-off and a policy discussion across these variables. So by not including bronze, and a basic fact about a state subsidy is that you can't just only give it to the new uninsured, right? So you have to spend a good amount of money on current enrollees, which is what we're talking about here. And that does have its value in buy-up, and we have a number of slides to go through on that as well. But what we're looking at here is a trade-off, because by concentrating the state subsidy and not subsidizing existing bronze enrollees, it allows it to be a slightly higher subsidy, which is what at the silver level, if you remember the charts, how it was able to bring down that cost on the sliding scale chart a little bit. And what the modeling shows based on extensive research is that that is what would attract more new enrollees, because they're very price sensitive to premiums. So the more you can bring down that initial premium, which is what we could do with a more concentrated subsidy, could get in more uninsured. And so the assumption here is that new enrollees, there's a value in gaining a smaller number of new enrollees because they're harder to get and they're currently uninsured, which means the impact is much more significant to them of not having any coverage at all than the impact would be to allow people who are currently covered to get better coverage. So that's a little bit of the trade-off there of like the numbers aren't as big, but the impact is much bigger to bring someone from uninsured to insured. And then on the total eligible piece, that does, or the current eligible piece, yeah, so that does not include bronze, but we would expect that up to half, maybe more than that, would move to silver or gold levels of coverage. And we have some other slides talking about that availability of coverage at the same cost they're currently paying, but for better coverage. So we think that would get above 200,000, which makes that trade-off, that difference in the total eligible not as significant. while we're also benefiting and being able to attract more uninsured in with a bigger benefit to getting, again, someone from uninsured to insured.
So Devin, we should think about 180,000 is really 200,000 there and not,
Yes.
okay. Other questions for Devin? Hey, Devin.
Next slide. So we did want to look at the access to silver plans again, because the modeling has shown that there is a lot of impact by getting to zero, especially when you're looking at bringing in folks from the uninsured, currently uninsured population. So looking at this particular income range between 151 and 200, currently about 34% have access to a $0 silver plan. That jumps to 100% in the proposed model, slightly less in the flat dollar models, and then much lower on the young adult subsidy, just because it's a much smaller population, looking at not using income as the basis. And then on the next slide, to go into a deeper dive on this, particularly for the proposed model, it shows that at different income levels, what people would have access to. So you can see 100 to 150, there's 100% access to zero cost bronze, silver, and gold, which is why the proposal is to have the subsidy start at 151, because the federal subsidies pretty much provide such a rich benefit at that point that there's not a lot of value in adding more to that. So picking up at the 151, you can see how it brings that population into having access to free bronze, free silver, and free gold at 100% across the 151 to 200% population. So that's triple the amount of access to lowest cost silver, higher access to gold. And then when you go one more income level up to 201 to 250, there's still a significant benefit. So you're seeing there that 96% already have access to the lowest cost bronze plan. You're seeing triple access to lowest cost silver and about 50% more access to lowest cost gold. And this also demonstrates sort of the question around further subsidizing bronze, is that it already is pretty heavily subsidized when you're looking at the 151 to 200% population and that next bracket at 96%. Again, it's sort of subsidizing that entire population when many of them already have access to a $0 bronze plan, really is sort of limiting in value of what it can do for those individuals. You know, it might decrease their premium savings, but it doesn't allow them to buy up at the same rate as if we concentrate that funding on the silver and gold levels. 251 to 300, again, that sort of decreases in value as it gets closer to 300, so we see a smaller impact on that range. Next slide. Next slide. There we go. All right, so this is another way to look at this too, of trying to put a dollar value behind the ability to buy up. So as you can see in this chart, this has the average out-of-pocket cost per member per month. So the silver amounts vary because of cost sharing reductions. So by these different income brackets, based on cost sharing reductions, it has the different lower levels at lower FPLs, and then it progressively gets higher. But take the 151 to 200% bracket for a minute. If someone's currently in bronze, their average out-of-pocket cost is $207. If they bought to silver, that would be $75. So they could save themselves $132 a month by buying up from bronze to silver. So if you take the relatively smaller $18 a month average, you're just using the amount from the recommended model, they can save up to 7 times that amount in out-of-pocket costs. And from a Pennie perspective, we would put in 18, and the consumer total would save 150, the 18 plus the 132. So this just goes to show how by allowing that buy-up power, consumers are getting even more benefit than we actually need to pay for from a cost perspective. All right, next slide. So one other piece we wanted to look at is from current bronze enrollees, what their ability would be to buy up and to leverage those savings that we just talked through. We did narrow this to what % of people in bronze would have a silver or gold at the same premium and the same insurer. These numbers would be even bigger if we didn't limit it to the same insurer, but we did want to do that because we know that consumers do sometimes have very strong preferences and for their current insurer. So we wanted to try to take an approach of looking at that impact that's sort of attuned to that consumer behavior of usually trying to stay within the same insurer. So when you look at that for these two different income brackets, you see, for example, currently only 5% have that ability to buy up to silver or gold at the same premium in the same insurance company. And you see significant increases across all of these models, with slight variations. The recommended model would be at over 50% of people between 150 and 200 would be able to have that buy up potential and get those savings that we talked about on the last slide, the $150 savings per month, up to that amount. And then at the 201 to 250%, less of an impact again, because it's a relatively smaller state subsidy, but there's still almost a 10% increase for that group for the recommended model. Colleen?
There's a question from Colleen.
Or just I'm just curious, did you look at all, this is, interesting information. So I'm just curious, when the ARPA subsidies were extended, I guess that went to everybody. So I guess I'm just trying to see, did that was essentially giving everybody subsidies, right? That could have made silver plans more affordable. Did we see people actually making that move from bronze to silver? Do we have any stats that show what happened with the extended ARPA subsidies and the effect on the market here in PA?
We have definitely seen a noticeable shift from bronze to silver and gold over the past several of years. So, we did just have a limited period of time before the ARPA subsidies went into place as Pennie, but we have seen a shift. And I think there's also been some other, dynamics that have resulted in that. But I think we have seen that shifting to higher levels of coverage.
It'd be great if we could see any of those numbers too, just to understand, to see how it truly plays. My worry is just that a lot of consumers with existing coverage, they don't pick their heads up really, and they just automatically renew their plan. So we may not see the shift that we anticipate from existing enrollees to buy up, because people just, I think as our data shows, the majority of enrollees don't make active changes. They just automatically renew, even if it may be in their best benefit to do so, right? So just curious, thanks.
Yeah, and we do have the policy where if it's the same plan available now at the same or lower cost, that we can automatically renew them. So we would expect to see a bigger impact there. But we can also get those numbers just to compare the first few months of Pennie existence to where we've seen since then, as far as the bronze, silver, and gold enrollment.
Okay, Devin, what else?
Next slide. So we did just want to talk through, because this is on a very tight time frame, as we all know, and why we're discussing this today is really, having to move a lot of pieces at once while we're having the discussions on the legislative side. So we did just want to talk through the feasibility and risk assessment side. So we do think the first two models the ones with low to medium risk, would be possible and feasible to implement on a very short time frame. Our technology vendor has implemented something like this before. So the flat dollar model does reuse the most of that, the maximum amount of that technical implementation. However, the sliding scale, because it's based on what the federal subsidies are based on, is also feasible to implement. It will require slightly more testing, but that's really the maximum impact that it would have to make sure that using a percentage-based subsidy would just require more operational testing on our side. But again, we believe that is feasible. The young adult would provide unique challenges because that particular structure has not been done so far, and so there could be more unintended consequences on a short time frame. The bronze versus no bronze doesn't change the risk in either direction. So just wanted to share that update as well. Next slide. So for the summary evaluation, as we've been talking about, the recommended one is the sliding scale premium percentage, because we think that generally has the highest number of current enrollees who benefit compared to the other two models, and also paired with some of the higher levels of new enrollees, especially compared to the flat dollar. It has some of the greatest impact on morbidity to improve the risk pool, and has the middle or lower costs per beneficiary. So that is sort of the recommendation and why that one was zeroed in on. And then on the next slide, which I think is the other component, is on the excluding bronze plans. So the recommendation is to exclude bronze plans, really sort of driving at the ability to concentrate the subsidy in a way that draws in more uninsured, while also making sure that we are providing people with coverage that they can use and has those lower out-of-pocket costs. I think further subsidizing people who currently have bronze, while it could, provide that benefit of a premium subsidy, it doesn't really provide the incentive or that value of reducing the out-of-pocket costs. Again, a lot of bronze plans, having $8,000 to $9,000 deductibles, again, is, up 30% of 30% of the incomes that we're talking about for this population. So, I think really the value of excluding bronze plans really allows us to concentrate it, get more uninsured in, not continue to exacerbate the issue that we do see where people buy only on premium because, not taking into account those other factors. So we think this would really get the most benefit from both a premium and a cost sharing perspective to exclude bronze plans. We do think this would require targeted outreach to really work with people who do currently have bronze and who could see the most benefit of buying up, to do that during open enrollment and really make sure that they understand those options. And then we do have that lever of being able to automatically do it for part of the population as well.
Okay, any other questions for Devin about the methodology or the data? Oh, did you have one more slide, Devin? I'm sorry.
Yep, just a summary of what we talked about, just the overall benefit of a state subsidy to improve the economic and financial security for individuals, improving health outcomes for enrollees with better, more consistent access to medical care. We do know another state actually saw more use of or fewer delays, fewer people reporting that they delayed care when they were able to reduce those cost sharing barriers. And so, better retention of the population, people able to maintain coverage in the having it be more affordable, and generally strengthening the individual market. So that's at a high level. And then specifically, the proposed model would, again, address those premium cost barriers and the out-of-pocket cost barriers as well, which we think would help improve health outcomes because it would allow people to access care for chronic conditions, in addition to having financial protection against medical emergencies. So on the last slide, it's just compiling this proposal again, that the proposed approach would be this applicable percentage sliding scale model.
Any other questions for Devin? Just that, that's just tough, Devin, the $30,000 wage earner with a $9,000 deductible. I don't know when you would ever decide to go to the doctor, except for preventative care and potentially emergency service. But if it's an emergency service, you probably go to urgent care first to see if you could save money from your $9,000 deductible, because that's enough to bury your family. That's just tough. So, obviously the idea would be to promote people to, or encourage people to purchase coverage that's more affordable, both in terms of premium coverage, but more affordable in terms of coverage you can use, because it's important for the overall health. We're not going to vote today. I think the idea, as I mentioned earlier, was to have the vote to decide next steps and kind of spending on the tech lift at our July meeting. So any other questions about that? Because otherwise my intent would just be to move forward with the recommendation so PID can have conversations, that the board has a general consensus around sliding scale. And I would say no bronze as we continue to plan forward. That would give at least the legislature a limited number of data points that we can focus on that would help from an administrative perspective, from a PID perspective, in terms of talking about what the program may actually look like in 2025 and allow Devin to continue to kind of work in that general direction because I think we're under time constraints, and I think everybody knows that the budget is a June activity. If we don't meet these deadlines, then we're not able to do it in 2025. And then, I mean, we lose a significant potential population with the Medicaid group that has already come over, that continues to come over. I think this is the 2025 is the opportunity. So I'd like to continue moving forward with this proposal with the sliding scale, no bronze as mentioned, as recommended. I understand there's been a number of conversations and people are general supportive, but it would take any questions or objections to that approach. Go ahead, Colleen.
No objections. I just appreciate, I know a ton of work went into pulling all of this together, so I appreciate the time that Devin and the team put into putting all of this together. Just one question, as far as what will be shared with legislators, is that going to be this full, deck that you've taken us through, or is it really just the recommended option, just for an understanding of what's going to be shared?
But this deck becomes public.
Okay.
So, I mean, they'll have access to this. I've shared abbreviated kind of data points from it, but we'll be able to even tailor it further now as PID at least has those conversations.
Great, thank you.
Alexis?
Yeah, also no objections. A question is whether or not we can get a view of sort of projected applied subsidies and new enrollees by region. Rating
Devin,
area.
was that broken down, Devin, further than general, or I don't know that answer.
It wasn't. We have been looking at that because I know that was a question raised before, and we're still trying to figure out the best way to tie. And we also wanted to have the working model in order to do that against. So we will continue to work on that and see if we can put something together that at least approximates the impact.
Okay. Thank you.
Any other questions, thoughts? Okay, appreciate all the conversations that have gone into this, and certainly Devin, the work of the Pennie team on pulling this together. I think it's a really important initiative, a really significant opportunity, and look forward to continuing to work collectively as a board. And I think this is helpful measure as we continue those conversations and continue to build towards what this could be pending legislative enactment of the proposal and funding as well, as we've discussed prior. So with that, we'll move forward as discussed, and we'll move on to the next agenda item, which is our income verification proposal. And I think, Devin, I'm going to kick it back to you for that.
Yep, thank you. So wanted to introduce our Director of Operations, Rob Schobert. He joined us at the end of 2023 and brings with him a lot of experience, including on the eligibility and marketplace side. So it's been great to have him, and he's going to walk through a change that is coming out of some of this final rules. So I will turn it over to you, Rob.
Thank you, Devin. So if you recall, during January, we discussed the proposed rule where CMS wanted to start requiring states to pay for use of their verified current income source, which is Equifax. They did end up finalizing the rule. So effective July 1st, they're going to require us and the other exchanges that utilize this service to start paying for access to this secondary income database. So Pennie is actually seeking approval to continue using the service for up to 1 year, with the reevaluation to be performed in 2025. Currently, just for some background information, What we currently do is our system automatically checks federal data sources. So that includes the IRS, and we use that to verify data or consumer information, including income information. So there are primary sources that we utilize that covers the vast majority. Then there are also secondary sources like the Equifax check. When that comes into play is if a household's income is inconsistent with the IRS data, then we attempt to verify that income electronically using current income information that is available through Equifax. It's worth noting that the CMS rule change only applies to the secondary or this Equifax check, and it does not actually add costs to the primary checks that are run through the other federal data sources. The reason that we think that this Equifax, or the reason we use this Equifax check, is to verify household income without necessitating the need for those households who are impacted and they can't have their information verified through the IRS. Instead of having them have to upload income documentation and have our staff review that documentation, it's easier for them, in most cases, to actually just get the Equifax check done. Then they don't even have any administrative burden added to it. So the next slide is going to show us what that means in terms of consumer impact. So as you can see, we continually seek to improve our income verification process, but we do still see intrinsic value in utilizing these electronic verifications in order to help eliminate those administrative burdens. We want to quantify it. So just looking at March, you can see that the Equifax check was used to verify 934 income records, or about 21% of the 4,487 responses that we received from Equifax. If we had to pay for the service back in March, that would have equated to about $24.22 per verified income record. It's also worth noting that historically, 25% of the households who need to submit documentation to us in order to verify their income end up losing APTC. That would mean, if we extrapolate that out through the year, that the continued use of the Equifax service will avoid administrative burdens for roughly 16,000 individuals. And more importantly, it'll also avoid loss of APTC for approximately 4,000 individuals. Based off our current utilization, we do estimate that there would be yearly cost to Pennie for the rest of 2024 of around $700,000. And we do estimate that that would increase to about $1 million in 2025, 1.14 million in 2026, and finally 1.3 million in 2027. So on the next slide, we list our proposed plan. What we want to do is to continue exploring other secondary data sources to determine if they are viable, and then compare their costs and benefits with the continued use or the continued cost of using Equifax. One example we have, and again, this is very preliminarily, we still want to go in and do a deep dive with this and do a cost benefit analysis to determine the best alternatives. But one possible alternative would be, as a secondary data source, would be the quarterly wage data that the Pennsylvania Department of Labor and Industry supplies to the Department of Human Services. While we are doing this review, though, we would like to maintain access to Equifax so that we could continue to avoid those administrative burdens for a portion of our population. And those administrative burdens, again, arise through the manual verifications that have to be done when a consumer has to submit income documents and us review it in order to maintain their APTC. So our proposal is to actually continue utilizing Equifax at least for the next year while we explore these potential alternatives. At that point, we will then propose next steps, which we would do no later than the second board meeting in 2025. For this specific proposal, we do ask for 2 board votes. The first is to receive approval to continue our use of Equifax, and the second is to receive budget approval for the additional spending of up to $750,000 for calendar year 2024's continued use of Equifax. So that's probably a lot of information. Does anyone have any questions?
Yeah, Rob, what happens if we do nothing?
So if we do nothing, we would still be able to use the primary sources that we have, but there would be a subsection of our consumers who would be impacted because they wouldn't be able to have their income verified electronically. Those consumers would then be issued a data matching inconsistency. They would hopefully submit information to us. If we could verify that information, we could maintain their APTC allotment. But like we said, historically, about a quarter of the households that we actually request that documentation do not respond or do not submit adequate documentation. So there would be a subset of people that would otherwise receive APTC if we had this secondary check, who no longer would receive APTC.
Yeah, that's not great. Colleen.
I was just, I think it's money well spent, because that chasing people down to try and get the verification, that is a challenging task. I think even on the carrier side, we've tried to help support some of those efforts in the past, and it's still some people just don't take the action. I think we even saw it with the unwinding efforts, right? With people being able to keep their Medicaid eligibility, people just didn't respond, and it could be for a multitude of reasons. But if we have a way to simplify the process for a significant number of folks, I think it's, money well spent.
Yeah, I agree with you. Anybody else with thoughts, questions?
Hi, this is Frank with Capital. Can you say a little bit more about the second potential alternative? Is that a huge lift? Is that why it's something that would have to sort of come much later versus something that might be able to be done more quickly since it already exists as a process?
So to be completely honest, we are still evaluating it. So we don't know how large of a lift it would be, but we want to make sure before we pursue that endeavor that it's also cost efficient, right? So there would be costs involved. We want to make sure that if the costs are near the level of Equifax, do we anticipate that it would be, would more people be verified via that other alternative secondary source, or would less people be verified? And then additionally, are there ancillary benefits that we might see? So you'll see on this slide, the second bullet point under alternatives, you can note that Equifax requires a credit history. So some of the alternative sources might have ancillary benefits, like those who do not have a credit history, so recent immigrants or people that are unbanked. We might be able to see some benefit from the alternative sources as well there. But we really wanted to just buy ourselves enough time to do a thorough search for alternative sources before making a decision to try to move into that other direction.
So we just don't know at this point.
Yeah, it's still very preliminary.
Thank you.
Yep.
One other question as I look at the proposed motion, the second part of it's to increase the budget by $750,000 to pay for the use of Equifax through CMS to verify income data. So CMS would bill us. We wouldn't work with Equifax separately. It's organized through CMS.
As part of the commentary that actually was asked if we could go directly to Equifax, if the state exchanges could, CMS did not want to go in that direction. So we do have to go through them. It's still part of the data hub that we use. Otherwise, it just is a secondary source that's utilized. And it's worth noting that CMS actually does charge an administrative fee of about 12 cents for each response that's received from Equifax when they're acting as that facilitator. But yes, we would have to go through CMS to continue this use.
So the verification piece is being done on the back end at CMS versus here, and then they're charging us to use the vendor that they've contracted with, and then they're charging us a user fee for using it on top of
Yes, but the only time we are charged is not when we make a request. It's only on responses given to Equifax. Now, those responses could go either direction. So it could be they were not able to verify the individual's income, or they were able to verify. So there are two alternatives. But yes, anytime there is a response from Equifax, CMS then charges us, which does include that administrative fee.
I don't want to beat a dead horse because I think generally it sounds like we're good and have limited choices. But if we didn't do Equifax, wouldn't we not then do the verification through CMS? We'd have to do it separately ourselves if it's CMS's vendor.
So if we didn't do Equifax, we would still get access to the IRS data, the Social Security Administration data, because that's all free. So we'd still get that response in our data call, but we wouldn't have access to the secondary information.
We'd have to do that separately if we wanted to do some.
Yeah, so if we pursue an alternative, we would have to build that in.
Yeah, that's wow. Okay. Any other questions or comments? So the staff recommendation is two different motions. The first would be to continue using Equifax as an income verification data source through June 25. The second is to increase the budget for the calendar year 24 by up to $750,000 to pay for the use of Equifax through CMS to verify income data until the end of the year. So I'll do those separately. Do we have a motion to continue using Equifax as an income verification data source through June 25?
I'll motion.
Colleen moves, looking for a second.
This is Tia, second.
Tia seconds. Any discussion on that first motion? Hearing none, all in favor say aye.
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 Any opposed, same sign. Hearing none, motion 1 carries unanimously. The second motion we're looking for is to increase the budget for calendar year 24 by up to $750,000 to pay for the use of Equifax through CMS to verify income data until the end of the year. Do we have that motion?
This is Cheryl. I'll make that motion.
Cheryl moves, looking for a second.
This is Antoinette, I'll second.
Antoinette seconds. Any discussion? Hearing none, all in favor say aye.
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 Any opposed? Hearing none, motion carries unanimously. Thank you all. Appreciate the work of the Pennie team on that. It doesn't seem like the CMS gave us a whole lot of choice, but certainly appreciate the response on how we move forward. Not a lot of timeline they gave us either, but neither here nor there. So moving on to the next agenda item, we'll have a discussion of the plan simplification proposal. And the agenda item is simply to discuss this. Would like to postpone any votes to our July meeting. Really just wanted to have the discussion, or not July, because what I don't want to do is get in a pattern where we just continue to have emergency meetings and then we're almost meeting every month. So I would continue this until our August meeting, which is the next cadence of meetings that we would have, because there's not the urgency on this one that we have on the subsidy wrap discussion that I think we need to come back and have that vote in a more timely manner. This one, I think we can allow more opportunity for continued discussion, because it's my understanding that there's just a couple of issues that we still need to work through, and that all parties, I think we are close. So to the extent we're close and get to consensus versus have to take a fractured vote, I think we should work towards that consensus. That said, we have been doing this for a long time, so I would plan to take a vote in August. Hopefully we're able to get to a good place before that, but otherwise, I mean, there are the votes to move something, and I think we would look to have that vote in July or in August. So, Devin, if I think you and David are going to kind of walk us through where we are, how we got here, and kind of potentially some next steps on the discussion.
Yes, thank you. So as you all know, we had talked about this in February, and so this is a continued conversation, and David is going to walk through the discussions that have happened since then, the revised, where we are with a revised proposal, and then we can have discussion from there. David?
Thanks, Devin and Mike, for teeing me up. So before we talk about the Simplify and Plan Shopping proposal specifically, we did want to take a step back and kind of, while the focus has been on the proposal itself, I think we wanted to remind everyone that this is just one component of a multi-year, multifaceted initiative to improve the plan shopping experience, with obviously the customer experience being at the center of everything that we are trying to do. So, and we really want to articulate those values here. So our goals are, with this entire project, is to ensure our customers have access to high quality health and dental plans, ensure that our customers understand the plans available to them, and that they are satisfied with their coverage after they enroll. And we've talked about, we've had this initiative, the Plan Quality and Consumer Choice Initiative, for some time now, and this is just one component of that. Next slide. So to kind of remind us of kind of where we are on the timeline, we set out I believe we started this project in 2023, last year. And we really try to identify what are those opportunities that we have to make the plan shopping experience better for our customers. And we started this year, so for plan year 2025 or for plan year 2024, by taking the state option to automatically move bronze enrollees who are eligible for cost sharing reductions into a silver plan if that silver plan features a equal premium from the same insurer and within the same product type. So that's that was one initiative that we did to kind of ensure that folks in bronze plans who have that access to the richer benefits and can move to that without paying more in premium are afforded that opportunity without having to take any action. Our plan certification policies that will go into effect next year kind of build on that. And specifically around improving language access. We have a significant Spanish-speaking population, and we've done a lot in our application and our website to improve language access for Spanish speakers. But we have moved to improve that within our plan shopping experience as well, so that Spanish people who are primary Spanish speakers have access to the summary of benefits and coverage in Spanish. Of course, for 2026, we still have our simplified plan shopping proposal. And then really based on that is going to come kind of the rest of the project. And we've engaged with external stakeholders quite a bit on how we can do that. So other things to come include additional plan filtering options, the affordability algorithm, and providing enhanced tools and resources on Pennie.com so that people have access to the best information to enroll in the plan that's right for them. Next slide. So getting back to the simplifying plan shopping proposal. As we talked about last time, we really value having a robust, competitive marketplace that allows for both new entrants into Pennsylvania, as well as allowing existing insurers to enter new markets. And we really want to preserve that. But at the center of this proposal is really our customers. And it doesn't matter whether they're in urban counties with 70 plus plans available or rural counties with maybe 20 plans available currently. We want a proposal that works for all Pennsylvanians. And we also want to do so while keeping in mind that about 2/3 of our customers are passively renewed. They like their plan or they don't see any reason to change it. And so we renew them and they keep it. And maybe they don't even go into plan shopping at all. So we also want a proposal that minimizes plan disruption for them. And then, of course, we've been discussing this for a long time, and throughout these conversations, we really come to appreciate the fact that each insurer has its own unique approach to the marketplace. You all have your own unique product types and kind of your business models. And then, of course, all Pennie stakeholders kind of bring a different perspective to the discussion, and we really value that. And that's important to keep in mind for us as well. But a lot of this is just to ensure that we are keeping the customer, every customer, whether they're in Philadelphia County or Elk County, we're keeping every customer in mind as we move forward. Next slide. So this is kind of a refresher from what we talked about in February. Our original proposal was pretty simple, and that was to establish a consistent number of plans that can be offered by each insurer legal entity as 3 in each county per metal level and per product type. It fairly straightforward in terms of being able to kind of understand exactly what the proposal was. And again, we're starting out with the goal of simplifying the plan shopping experience without undermining plan choice or insurer flexibility to adapt to the marketplace. Next slide. So we've been very busy since that February board meeting. In March, we met twice with the external PQCC working group that we had already met with a couple of times, but we brought them back in March to specifically talk about areas of where we could forge additional consensus as to what our simplifying plan shopping proposal should ultimately look like. So we brought everyone together, including all the insurers, all the insurers were invited. Sister groups were invited, brokers, broker representatives, and advocates as well. We had really good turnout for both of those meetings, as there's obviously a lot of interest in this proposal, and we brought them together with the focus of getting to as much of a consensus on the best way forward as possible. So what we're going to talk about in terms of of what we're looking at now really reflects those conversations, as well as our continued efforts to find the right balance between insurers who are seeking additional flexibility with the policy, as our internal concerns about the impact of the proposal on rural areas and current enrollees. And we also heard that in our external meetings. And then, ensuring that other key stakeholders have their voices heard on this initiative as well. So we reviewed all the feedback. We've drafted an updated version. We're not going to vote on that, as we talked about, but we thought it was important to kind of bring the update here, because not only I think as we continue to evolve in our thinking about this policy, I think it really must reflect all customers across 67 Pennsylvania counties, and it must reflect the voices of all stakeholders. Next slide. So before we go into the kind of the current proposal, I want to take a minute to discuss alternative proposals that have been offered that we are not recommending. So a few groups have offered that Pennie should go further than the original proposal and go to a 2-plan limit. So a 2-plan per county, per legal entity, per metal level, and product type, with no additional plans, no additional plan process. The reason why we are not recommending such an approach is that when we did an internal data analysis, we found that there are several counties where over half of plans would be removed, and it would leave many rural counties without adequate plan choice. So again, taking that 67 county view of things, our concern is that such a limit would disproportionately impact rural areas with less choice today, and again, we don't want to do that. We also found that about 1 out of every 5 Pennie customers would have their current plan eliminated, which is a lot of plan disruption, and we want a better balance than that. There was a proposal just, well, why doesn't Pennie just go to a 4-plan limit? And the reason why we're not recommending that is because there's not enough value in doing so. We don't get the impact that, well, the 2-plan limit was too much of an impact. 4 plans is not enough. It doesn't do enough to move the needle. It doesn't do enough to reduce the number of plans that customers have to sort through in those counties where we see an overwhelming amount of plans. And then maintain the status quo. We just are not comfortable recommending that for reasons that we've discussed previously, but we continue to feel strongly that we do need some type of policy to move forward with in order to maintain our policy of allowing all comers. We want to continue that. Next slide. So our revised proposal would kind of build on a 3 plan limit in each county, metal level, and product type, by allowing each legal entity to offer 1 additional plan in each of the gold and metal levels if the insurer can demonstrate that the plan would improve access to care for individuals with chronic conditions. So this is kind of a handy table to kind of demonstrate how this would impact the original proposal. It's adding 1 additional silver plan, 1 additional gold. It's not adding an additional plan in each of the product types. It's just 1 additional silver, one additional gold. So for some plans, maybe it's a silver PPO, or maybe it's a gold EPO, but only one of each metal level. And the reason and the reason why it would be silver or gold is because there's not a whole lot you can do in cost sharing within the bronze metal level. The AV limits just don't really allow for a ton of innovation in terms of access to care and reduced cost sharing. So the way that we're thinking about this now is that in order to get these additional plans, the insurers would submit a form outlining how the additional plan would improve access to care for individuals with chronic conditions or other health needs compared to the other plans within their 3-plan per metal level limit. And we also they would also have to attest to or demonstrate that the customer would be able to distinguish between that additional plan being offered and from the insurer's other plan. So the naming convention should be clear that this is the additional plan, or maybe something in our system would alert the customer to that. But we would want to flag that in some way that this is the additional plan and that it's here because we believe that it adds value to the customer plan selection. It builds, it does more than the other plans might in the suite of plans to reduce barriers to access to care for those with chronic conditions. And then we've talked with the insurance department extensively about this, and we would work with them to review the additional plans submitted in year 1 and provide a report to the board of directors in early 2026 to evaluate how the plan process worked. So what were the additional plans submitted? Do those, in reviewing those plans, do we think that, the extra plans submitted really do meet the spirit of what we're going for with this proposal? Next slide, please. So we've spent some time on this in the last meeting, but kind of the current state of health plan offerings and why we continue to believe we need some type of policy in this area is just, the every year, most years we've added another medical insurer, which is wonderful, and we've added average more insurers per county. So that means we're getting new entrants into the market itself, and we're getting new entrants into different markets across the state. Great thing, but as we've done that, the average number of plans offered per county has gone up, and the kind of maybe the complaints that there's too much choice, it's too hard to understand choice, has gone up as well. You can see some of those larger counties, or the counties with the most number of plans, some of them on the right. And so I think that's just to illustrate, it's not just big urban areas that have a lot of plans, it's also like smaller area like Northampton, 92 plans, that's the most we have in any county, not a large metropolitan area. Schuylkill County up there with 76 as well. Next slide. Oh, I have a question.
Yeah, this is Cheryl, UPMC. Just a question. The complaints that you've gotten from consumers, do they cut across all the counties, or are they primarily centered on the counties where you have almost twice the number of plans?
I would say it's probably it's anecdotal feedback, but we do get we get comments from customers as well as folks who work with them that it's just a lot to wade through, and it's hard in a lot of cases to understand the differences between the plans, and so customers end up confused and want to walk away because it's they just find it overwhelming. Antoinette?
Yeah, I just want to talk a little bit about this because we actually surveyed the folks that we enrolled across the Commonwealth. We've enrolled folks in every county except 2. And we found overwhelmingly that 67% of the folks we surveyed said there was just too much plan choice, and 50% actually recognized that they would be happier with fewer high quality plans to choose from. So that was, both rural, urban areas and everything in between, that we actually had conversations and surveyed marketplace enrollees in our universe. And also, just to note, those were folks that also sat down with a navigator, so they had additional assistance and were still overwhelmed by plan choice.
Other thoughts, questions? I know it's certainly an issue that at every NAIC meeting, I hear from consumer advocates more generally, even on the national level, that there's a bit of analysis paralysis when their groups are helping policyholders try to enroll. So I don't think we're unique in facing this significant number. And those of you that have sat with a neighbor or someone else to help them work through Pennie, I mean, the functionality is great, but it was a lot of choices when I did it. And it was challenging to go through the multiple pages of plan options and to try to find what may be the best one for them. Colleen and then Tia.
So Antoinette, I remember you speaking at the last board meeting about research as well, and may have even been in the deck. I'm trying to remember back. Is what you just quoted newer research or the same from before, and is it possible for that to be shared?
It's new. It's within the past 4 months. So the affordability data, we did the affordability survey, and then we did the plan choice survey. So the plan choice data is actually newer, so we can share that out, no problem.
That'd be great. Thank you.
Yep.
Tia.
And to piggyback off what Antoinette said, a majority of those folks are folks who we're actively engaging and talking to when it comes to enrollments, but there's a large swath, a universe of folks who do not talk to navigators, who just in passing are saying, hey, I did not enroll because there was too many plans. It was too much choice. I didn't know what to do. I got paralyzed and just chose nothing.
Other questions? Or David, I imagine you might have a couple more slides. So we'll turn it back to David because I don't see any other hands.
Thanks, Mike. With the updated proposal, we wanted to walk through, the potential impact on the impact we might have had on planning in 2024. I say might because, with the additional plan proposal, we're doing our best to estimate what the insurers might have done with those additional plans. But again, for 2024, we offer an average of 49.6 plans per county across all insurers, mental levels products. And when we did an additional data dive, we really found quite a big difference between those counties with the outlier number of plans and most counties within Pennsylvania. So the top 10 counties with the greatest number of plans today average nearly 84 plans. And under this proposal, the modified proposal, they would experience an estimated 20% reduction in plans. So today, there are 2 counties with more than 90 plans on offer and 6 counties with at least 80. Under the modified proposal, no county would have more than 74 plans. We also found that at the bottom there were more plans that were well below average than way above it. So the bottom 14 counties with the lowest number of plans today, with an average of 29, would experience an estimated 6.8 reduction. And we looked at the bottom 14 counties because there were 5 tied for the 10th fewest with 33, I believe. And so we feel that this proposal really concentrates the impact at those counties with outlier number of plan options without severely impacting those counties that have a much more moderate number of plans available. So some of the highlights here, we talked about Lancaster, Philadelphia, and Northampton. Those 3 counties would see the biggest, some of the biggest impacts. And I wanted to put in a rural county, McKean, to kind of demonstrate the balance that we're trying to hit here. Currently, McKean County is one of a few counties that have 21 plans available. This proposal as modified would reduce that number to 19. So we believe that, you know, the net would be loss of 2 plans. And, you know, I don't know if we necessarily want to go much below that for counties at the lowest levels of plan options. So based on our internal analysis, we estimate that the largest plan reduction would be approximately 18 plans in those counties. And then again, much more limited impact on rural counties. So the modified proposal, I think, again, the impact is with those counties that have just overwhelming amount of plans and less so on rural areas or other counties that don't have as many. Next slide. So we wanted to compare this proposal and the impact of it to the one we put forward in February, and then also compare it to what the FFM is doing. Since obviously, you know, we compare ourselves against the FFM, and we want to, as Pennsylvania's state-based marketplace, we seek to provide a better experience, better product, better everything than the federal marketplace. So the February proposal, again, three plans per county per legal entity, metal level, and product type. Gotten used to saying that fast, so I apologize. With no additional plans, we see a projected average number of plans per customer after the intervention as 37. Today's proposal, with allowing 1 additional plan in silver and gold, we would estimate that there'd be an average of 43.4 plans available. Compared to the federal marketplace, so the FFM, yes, they have their non-standard plan limit is 2, but their plan limits also are inclusive of dental and vision. So it looks like it's 2, but really they allow those dental and vision variations there as well. They do allow for additional plans and really almost an unlimited amount, as long as the insurer can demonstrate that the plan offered would reduce cost sharing pertaining to the treatment of chronic and high cost conditions of at least 25% for the entire year. So as long as the insurer can do that, they can get, it doesn't seem to be a limit to the number of additional plans that there could be. And they also have, of course, standardized plans, and those are required in every service area where non-standardized plans are offered. So the 2025 NBPP, the final NBPP, estimates that the average healthcare.gov customer would still see 66.2 plans, wherever they're shopping. So even with their plan limits, they still see considerably more than a Pennie customer would see today, and especially if we do implement one of these proposals. Amy?
I just want to clarify but the 66.2 includes the standard plans as well. So that does include plans that are easily comparable to each other because of the standard costs.
Yes.
Any other questions on this slide? Colleen?
I guess I don't know if questions. I mean, I guess just a couple of points. One, I don't know if we have another slide after this. Is this the final I can hold? I can't remember.
We have a couple more, I think.
Okay. I mean, I guess just because we're here and we're seeing the language, I know it was on a previous slide, just with the additional plan allowed. I know that's one of the things that's, I guess, one of the questions I have raised is just the definition of what will be allowed. And I think what I saw earlier, the proposal was to follow the federal marketplace with chronic and high cost conditions. And I guess from my perspective, I think there's an opportunity to broaden the definition of innovation to go beyond this. I think most people who have significant chronic conditions and high cost conditions are probably already covered. And, one of our goals, with Pennie is to attract more people who are uninsured to the marketplace. And I don't know if just limiting our definition of innovation to chronic and high cost is necessarily going to bring new entrants into the marketplace.
So, yes, your comment is well taken. I will say that one of our external work groups, the first meeting we had in March when we brought that group back was to say, okay, there's a lot of calls for flexibility. What is the best way to do that? And really the consensus came out was, well, let's allow for some type of, an additional plan, really additional plans. Like that's where everyone wanted to go, that advocated for that. The second call was specifically about, okay, if we allowed for additional plans, what parameters should we put around them? And so we had kind of one proposal, or one kind of lane, is the chronic conditions. The other one we said was primary services. And, for those in the room, there was just not a lot there was much more support for chronic conditions, much more. I think that the sentiment was that, that is where the value is. And that's where, in terms of like demonstrating that value, from the plan, the plans within the regular limits to the additional plan, you can get the most value with the chronic conditions. It followed kind of what the federal government's doing. I think there was more support for that than it was for really any other type of model. So absolutely, we're going to talk about kind of what we want, what our next steps are with this. But I will say, at least in that conversation, the reason why the modified proposal says chronic conditions is because that was the pathway that garnered the most support.
Yeah, and I know that the planned participant from Independence did voice concerns with that approach, even in that meeting. So, I think people have introduced things like this in our market, has not been a big seller. We haven't seen uptick, and actually we saw the plans withdrawn. So I would just, continue to have concerns if that was the only way we were defining this.
Antoinette, oh, well, that's a lot of questions. So let's hold on the hands to let David finish the last couple slides, because I do think we need to identify what issues are remaining to be worked on between now and August. And I think the discussion will help narrow that. But David, I think you could continue to finish the story, and then we'll come in and ask those questions and provide that feedback so we can help determine how we move forward between now and August.
Yeah, I appreciate that. So there's just one more slide, and that's again to kind of articulate the current proposal that we're discussing today, which is again to allow each legal entity to offer one additional plan in the gold and silver medal levels if the insurer can demonstrate that the plan would improve access to care for individuals with chronic conditions or other high healthcare needs in an innovative manner. That's kind of the language that we came to for today. I do want to talk a little bit about the benefits and the challenges before we get to the next steps. I think the benefits, we want our customers to have access to the very best plans of every insurer, and we want that to be apparent to them. We believe that this is a compromise solution that addresses choice overload in some counties while maintaining access to quality plans in rural areas. And we believe that, the additional plans that are provided will provide meaningful choice for customers. I think honestly, the fact that, we're proposing to take an additional board meeting for this reflects the challenges that we have in bringing all diverse stakeholder interests together and developing a policy that works for the entirety of Pennsylvania. So I do really appreciate all the great conversation that we've had in these meetings and within the external work group. And we have tried to represent all of them in these discussions. So next steps, as Mike alluded to, I think where we're at today is that it does seem to be that further discussion is required as to whether we even have plan limits at the right level. Is legal entity appropriate, or is it is parent company better? We want a level playing field for all insurers, and we want to make sure that again that the plans on offer reflect the best out there for our customers, and that we kind of maintain that. Also, at the same time, we need to make sure as Pennie that we're still minimizing customer plan disruption by making that step up from legal entity to parent company. Does doing it by parent company work for our current crosswalk hierarchy? So we need to evaluate that. And then, as Colleen, you mentioned, it seems like there's still further discussion required on what the additional plan approach should look like, what the parameters should be, and how we should go about that. And then, again, we aim to have those discussions wrapped up at least the best that we can for a final vote in August. So I think those are really the two. Do we have the right level, the insurer business level in terms of plan limits? Is legal entity the right place, or is parent company better? Both for creating a level playing field for all insurers, but also ensuring that our customers are not disrupted more than they need to be from this, and then working on the additional plans. I believe that's where we're at today.
Oh, that was
That's
the
all.
last slide. I thought you had multiple slides, David.
The next
okay,
section's
so-
mine too, but
Well,
that's what it
there
is.
was multiple hands, so we'll see those hands go back up, and we can kind of discuss next steps further, hopefully limit the outstanding issues that we have and figure out how best we could talk about that, maybe continuing that separate work group. Cheryl.
Antoinette, did you want to, you were number one before. Do you want to?
No, I mean, I was just going to say, I think this is where Colleen and I agree. I think, we're not happy to see a process to add additional plans. I mean, we think 3 is enough, but I think to make us more comfortable with the idea, we just really need to see language around what does that exemption look like, or what does that plan look like? Because right now I just feel that that's not clear. If we're taking out chronic conditions, how does it not just become another plan that's no different from the other plans that are offered?
Excuse me. And so, and mine is similar. I just wanted to clarify that the discussion that will be had after this, or whatever consensus we're kind of getting behind right now, isn't limited to chronic conditions. In other words, when these work groups meet, or however we come to a definition of what innovation means, we're going to be we're not wedded to it necessarily being a chronic condition requirement. That's a question. And then number 2, just a statement that when you're talking about innovation, it seems to me that anytime you constrain it in a way, particularly limiting it to chronic conditions, you're constraining innovation that we may, at this point, we may not even be able to define what innovation is, tomorrow's innovation, and if you limit it to chronic conditions only, it just strikes me as very narrow and potentially disadvantaging consumers from ideas that are novel and you know, as technology advances and virtual care, et cetera, et cetera.
Yeah, I think if that question was being posed to Penny as far as the follow-up on that item, I think, yes, the idea is opening that to discussion about whether chronic condition should even be the limit, or if there's another way to really get at for plans to demonstrate that those additional plans are different in a meaningful way that is not tied to a chronic condition. So I think that seems to be, just from the feedback we've gotten, an area that everyone's interested in, and making sure that it's a meaningful difference in how those additional plans are created. Maybe less importantly, tied specifically to chronic conditions. Maybe that's a component of it. Maybe there's an additional piece that can be demonstrated. So I think, yes, to answer that part of it, at least from our perspective, we were proposing that to be sort of a conversation about whether that should be defined differently from chronic conditions or chronic conditions plus, or, you know, just sort of what that piece would look like to make it really try to be the intent, which is that it's something different and something new, and not, you know, a slight variation on something that's already covered in the other set of plans.
Colleen?
The only other comment I wanted to make is, I know a couple of times through this presentation, David has mentioned disruption. I just want to make it clear that by moving this way and setting a policy like this, we are potentially creating disruption annually, right? Like, I just want to make sure that that's clear, because if with these limits, every time somebody wants to add in another plan, if it's not if it doesn't meet the innovation criteria, or however we define that, and there's only one of those anyway, you're then having to shift members out of a plan, out of some other plan that's in the market into something new, which could cause disruption around what they pay, what their network, not just their premiums, but what they pay out of pocket, what their network access looks like. Consumers don't necessarily pay attention and may not wake up and realize the differences in their plans they've been defaulted into until they start using it in the new plan year. So there are downsides to this as well for the population who have been in this market for a number of years. And I think that we just need to make sure and just, I guess, make sure that that is also acknowledged, that there may be some upsides to limiting plan choice that consumer advocates see. From a carrier perspective, we believe more choice obviously is better for the member. I saw that, you know, there's language, I think it was on the previous slide, that says the best plans of a carrier. Who's to define best? Because each individual consumer should be finding the plan that is best for their needs, not by, you know, just what the carrier is saying is the best plan for them, right? So with plan choice, consumers get to make that decision for themselves. With limiting plans, there is potentially the opportunity for disruption of a significant number of members year over year over year. So I just want to make sure that that is acknowledged as we, you know, contemplate moving forward.
Yeah, I think, Kelly, not to completely disagree, but I mean, the companies will obviously look at what they're offering. And I mean, sometimes the market will tell you which one not to offer again. We talked about a proposal earlier that you would no longer offer the one that nobody enrolls in. And the companies oppose that too. So, I mean, if you have 27 plans in a county, I would bet they're all not up at 15,000 people in each one. I think there's probably a couple that are not of interest to the consumer, and that it may be an easier decision to pull some than, I mean, a significant turmoil and transition for a lot of people year over year. I think it'll start to bear itself out. And I mean, as you identify your best, most attractive products.
So, you know, I guess I'm looking at it from the membership that we have and where we see our plan enrollment. And I don't think that others can make assumptions about what plan we would eliminate if we were required to eliminate plans, because there are plans that we may want to keep out there available to consumers because of the network availability for those consumers, and moving them out of those plans could have significant cost implications for them, right? So they may not have as much enrollment as some of the other plans, but could be detrimental from a consumer perspective and an out-of-pocket cost once they need to access care, which I know was a big part of, our last big discussion. So I appreciate your perspective at Independence. My belief is that we have been good stewards of our product portfolio since the beginning of the ACA, removing those plans that we don't see a lot of market pickup on. But there are plans that we do, that we have in the market that I think would cause more disruption if they were to be removed than maybe for other carriers that have a smaller, amount of members that are currently purchasing their products.
Amy?
Thanks. So David, I wanted to go way back. You had earlier talked about why you are no longer not supporting 2 plans per level per entity, and you'd cited some numbers. Can you share the results of that study so the board can see why that decision was made? You said something like there'd be 50% disruption, but it sounds like it would be county specific. So I wanted to see if there was more detail that could be provided about where, 1 in 5 consumers might have to switch plans, really where the reduction's happening.
Yeah, so again, it's just an estimate. We're trying to predict, in cases where our original proposal would have removed plans in the gold and silver medal areas for an insurer. If our additional plan proposal added them back, if what would the impact be? So really it just eliminates a lot of plans. And we found that I don't have it right in front of me, but about, I think, 86,000 people or so would have, that might not be the right number, but it's a large number of people who would, at least according to our estimates, would have their plan eliminated. So doesn't, again, they could be crosswalked, but I think that would be, a pretty significant jolt to the system. And then just because, in some counties, like even the ones with large number of plans, that's where most of the reductions coming from, to go to a 2 plan per legal entity, per meta level, per county, etc. That would just, there are some counties that would maybe, like Philadelphia, and I'll need to check myself after this, but would go from like 80 something to 40 something plans. And that's just a lot. But yes, I'm sure we can get additional, at least our analysis of it, made available.
Back to Colleen.
And we have to contemplate disruption, not just year 1 disruption. If you were to have 2 plans in the silver tier, and you then, as a carrier, the following year want to introduce a different silver plan, say you had just those 2 plans that you currently have enrollment in, you had half of them in each of your 2 plans, you're going to disrupt half of your membership to then introduce a new plan because they'll be dropped into something else. Like, we have had a very stable marketplace with Pennie, and this is another way to create disruption on an annual basis, especially if you're going to limit it down to 2 plans. You're going to see a lot of disruption annually as people are, okay, if I can only have 2, then I got to pull this one out to put this one in. And there may be reasons people are doing that from a competitive perspective in order to attract more members to their plan. That is another component of this, right? So, is that what we want members to, on an annual basis, to have to be disrupted with what doctors they can see, what their out-of-pocket cost sharing is going to be? From my perspective, that's not what we're looking to achieve.
Yeah, I think it makes it hard to have the conversation when we keep saying 2 versus 3, because really it's 18 versus 29 in a county area and per legal entity. right now. And there are companies here that have multiple legal entities. So, I mean, there's ways to blow past 29 really quickly to be offering plans in a certain county. So, I mean, I think it sounds like the two issues that remain are if you do it at the legal entity level or the holding company level. I mean, holding company would hold everybody, I mean, on a more stable footing. And then kind of how we define what innovative plans or what the +2 plans would look like, unless there's going to be support for two. And I guess how we work on those two issues between now and August, I think is the question, to see kind of what consideration there may be. And I think, Devin, it's probably a combination of you working one-off with people while kind of bringing issues back to the fuller working groups that have been talking about this issue to try to iron it out. But I don't know that that happens without additional one-off conversations. And obviously we can't, unless the full board is going to meet repeatedly. I mean, you're limited on the number of people in those meetings, is why I say one-off. But did you have thoughts on how you would do that? And then I'll go to Alexis.
Yeah, so I think on the legal entity question, wanted to look at a little bit of that analysis and then develop a proposal or an idea about what alternatives there could be and what the implications for that would be. And then I think have some conversations here and there, I think particularly with maybe the any company that would be more impacted by a change like that. So I think that would be probably more specific one-on-one conversations. And then for the criteria, I think we were thinking that we could leverage the external work group for a preliminary run through of that, of, maybe sharing some draft language, having some more conversation on that. And then I think that would be something we'd want to share with the board early enough before the August meeting in order to get any reactions or any additional feedback and sort of have additional conversations. So kind of do a parallel track on that front.
Okay. Alexis?
Yeah, I don't know that this is going to be an immediately helpful set of comments, but I just feel like I need to get them out. I mean, I think what we're contemplating right now, sort of what's on the page, has disproportional impact on longstanding carriers with more enrollment than it does on new. And I think you're always going to hear that, like the carriers that were here kind of seeing the market through, who, yes, enjoyed enrollment after we rode out the bad times. Now it's like, well, you're just in the mix with everybody else. And oh, by the way, in the name of limiting choice and also causing disruption, we're going to make these changes. It seems counter to what we had started with. I would say the other thing is, I think there is, on one side, you might hear that there's an inherent unfairness if you do this by legal entity, because some have more than one. On the other hand, if you do it at the parent company, holding company, there's an inherent unfairness to those who have enrollment in, plenty of enrollment in products in more than one legal entity. So again, it goes back to those carriers that have been here, since the beginning. And is that what we want to do, is redistribute enrollment? And I guess the last thing I would say is, I hear the comments about there being too much choice. I worry that we are flipping to an assumption that there are fewer people, there are more people who aren't joining Pennie because there's too much choice than there are who join Pennie because they like the choice and have chosen. And meaning that some of those products fulfill different needs. I want something that's at this level, that has this type of benefits, that does or doesn't have adult dental and vision. Like I just, and again, I know that's not helpful because it doesn't, I'm trying to think through, how we consider all those things and get to, I also understand that 92 plans starts to become daunting. Probably more so daunting because there's 6 carriers. I say that because I didn't want everybody to leave with, your last statement, Commissioner, that sounds like we're in agreement on these 2 things and just have to work out the finer details for August. I don't think that's the case.
But yeah, I didn't mean to suggest we're all agreement on limiting plans, but the suggestion was if there's a vote, there's the votes to limit plans. And I think that helps bring us together to have these conversations. I mean, as a board that seeks to help the insurance purchasing public, we are hearing from consumer representatives. We are hearing from the individuals that sell insurance. We are hearing from the assisters that help people buy insurance that choice is overwhelming. At some point as a board, I think we need to hear that and consider what we think the response is. And I don't know that I would agree that the appropriate response is it's fine. We should be able to continue to market an unlimited number of plans. You'll find a good one for yourself. When we're hearing from all those other stakeholder groups that say they're challenged in finding that product.
Yeah, I'm not suggesting we do nothing. I just think we have to research more options to come up with something better than, hey, consumers, the choices you have made might not have been the best ones, and so we're going to limit.
Yeah, no, I hear you, and I understand that. And I mean, we've just been I think we started this conversation with Zach. So I mean, we're a year and a half, 2 years into whether and how to limit plans. We've moved past the idea of standardized plans, although I think there are people on the call that would support standard plans. I think we've moved past the idea of getting rid of the ones that don't sell, because to Colleen's point, the company may still find them attractive. There may be some cost sharing implications for individuals. Trying to find where we can find that balance is, I think, the last challenge that we have. And these are just a couple of the issues in finding a challenge. But if there's another way to do it that hasn't been discussed, I don't have that answer right now. And it seemed like this has been one that's been now kind of tested with stakeholder groups for a period of time and has some positive feedback on it. So I don't want to totally lose momentum and start over if we ever had momentum, but ultimately also, like, at some point you fish or you cut bait. And I mean, 2 years into a conversation about how you limit the number of plans on a platform is a long time to have that conversation.
And I would just add, I mean, we're the ones that are advocates for standardized plans, and I think we've come a long way compromising. If you ask me today, we'd want to go back to 2 plans. So I think saying 3 plans, we're meeting folks halfway. And I think it's not just about people walking away. We work with consumers that are just so overwhelmed. At the end of the day, they go eeny, meeny, miny, mo and pick a plan, and they're stuck in it and have the same problems you're describing when they're crosswalked, right? So I think we need to do something. The answer is not nothing. And I think on the advocate side, we've met you halfway, right? I'd like standardized plans, fine, 2. I think 3 is a fair compromise, and I want to see language about what another plan would be.
So Devin, I mean, I guess interested in, I mean, I think obviously there's a lot of work to be done between now and August. I think you're going to have lots of conversations as you pull together some thoughts, and maybe if there's some idea we haven't already talked about. There's other thoughts that come forward, but I mean, I don't think we bridge any divide by not having you try to work through some of these issues between now and then and continue the focus groups on them. I think Colleen, you had another thought?
So just as we go forward, I know we had talked about individual conversations, and sorry, Devin, if I missed this, but I don't know if there's opportunities to, even after individual conversations, to even bring carriers all together. I'm not sure what's allowed, what's under the rules or not, but I think that would be helpful. I do get a little concerned about all of the one-off conversations and everybody aligning on all of that. And it might be good even just to have, even if it's by constituent group within the board. I don't know if that's allowed, but I think that could be helpful as we prep for the next meeting, or if we get to another place where we're at least trying to get to consensus before we have a board meeting.
I think I would defer to legal, but I don't think a majority of the board can meet and not sunset that meeting. So that would, I think, be one limitation that you would
That is
say.
correct. Yes, that
Okay.
is correct, Mike.
Thank you. Okay.
Devin?
Yeah, and I think, well, I guess maybe Cheryl, and then I'll.
Yeah, okay. Cheryl?
I was just going to say that I do appreciate, Antoinette, your comments and the fact that, you feel that the advocates obviously feel very strongly about this and care about what the consumer experience is. And I know from our perspective, and I think the other carriers as well, we do as well. So I even though this discussion's been going on for a long time, I agree with that. And it's frustrating at times. I think it's such an important issue that I hope we all stick with it and try to come up with a good solution, because I do think we all have the same goal in mind.
Devin?
Yeah, I appreciate that. And I think just hearing all the perspectives, this is why this is particularly challenging. I mean, there is a lot of different perspectives on it. And, I think in the counties, especially that have the most plans, I think the overarching concern is that people don't really have a shot at finding the plan that works for them when there's so many choices that either look the same or feel the same, or the ones that are right for them are buried on page 5. And I think the way, looking at that from a perspective across the carriers, new, existing, older ones, newer ones, I mean, I think the same principle applies if consumers are not even able to get to the point where they're seeing those choices because there's so much noise in the way, then it doesn't really set them up for success in being able to find the plan that the different companies have, created with them in mind. So I think that's sort of the overarching, that people aren't able to get to the plan that actually works for them when there are so many choices. So, and it seems like that would benefit everyone for them to be able to have enough information and enough ability to be able to see that more quickly. I think what we hear across the board from our own call center, from the advocates, from a lot of different sources, is that the current state does not support that level of decision making. So yes, we will continue. I mean, I think this policy that we're at today has been the evolution of multiple policies and multiple discussions. So I don't think we're going to get to a policy that satisfies every single need of what every stakeholder is looking for from it. So that is the definition of compromise. So I think really this is one of those policies that it's gonna to get to something that is meaningful isn't going, means that there's going to have to be flexibility across all aspects in order to find something that's workable. We think that there's a lot to balance, and we think, we are close on something that really meets a lot of different competing, or not even competing, but just sort of pulls in different directions. So, look forward to continued discussion on it, but are really hoping we can do something productive for folks who are shopping.
And it doesn't get all the way to Colleen's point about inter meetings, but I think, Devin, we could use is as much as I hate the idea, but we could use the July meeting to at least check in on this issue, but not plan to decide it in July, but at least have a full board check-in because we're going to meet anyway on the emergency issue. So we can follow up at that time on kind of the progress that you've been able to make between now and then. I know, I mean, it's hard to schedule members meetings in the summer, right? I mean, you've got all sorts of schedules to factor in. It's hard to get this board together as it is. But I think we can work between now and then, plan to have a check-in then, if not earlier. I mean, if there's a reason to have a second emergency meeting and we need to do it before July, to bring the full group together, we could do that. But I think it sounds like there's enough work left to be done that probably 2 months is probably right on schedule for kind of a substantial research project or research work that Devin's going to do and try to navigate these last two issues to further narrow what we possibly would vote on in August. So, I mean, I think unless there's objection, I think next steps would be to plan to check in on this in July, but in between now and July, Devin will have one-off conversations. Perhaps there's meetings of fewer than half of the board, but working towards coming up with discussion points or voting points on the two issues that we see as outstanding and any other walk-on issues or suggestive solutions that would happen between now and then. Anybody have thoughts, objections to kind of moving down that path? Hearing none.
Comfortable. Yeah, I'm comfortable with that approach. Thank you.
Okay.
Appreciate
Hearing no additional thought, I think by consensus, we'll just move forward with that plan. Devin, does that give you enough guidance from us on kind of what our expectations are for you to try to bring this together?
Yep. Absolutely.
So you've got a work cut out for you, but you could do it. And Devin, I think we're more than halfway. We could break for a drink. Well, I said that awkwardly. You could wait for a drink till after the meeting, but do you want to break now, or how long do you think the CMS final rules conversation will take? Because I do want to give people a chance to break, and I don't know when the best time would be, and I recognize that we did not build it into the agenda.
I think now would be a good time. Yeah, I think
Okay.
that's the final rules. It's mostly just informational on what was in there. So yeah, now would probably be the best time.
So let's break now until 2:15, give people a chance to stretch their legs, grab a drink or whatnot. We'll come back at 2:15, finish those agenda items, and then we'll go into executive session and then come back for one final vote at the end. So appreciate that, and turning my camera off for 8 minutes, and I'll see y'all soon. Thanks. All right, that was about the shortest 8 minutes of my life. But Devin, I think we'll start to bring people back. We'll give it one more minute, so people can situate, and then we'll jump right in to the CMS final rules and talk about that before moving on with the agenda. So I think you are about good to start. I will talk slow, but I think you're about good to get started walking through the discussion of the next couple of slides, and I'll defer it to you.
Okay, great. Well, CMS put out its final rule that had been proposed as their annual rule. So we just wanted to highlight a couple of pieces of that for informational purposes for the board. Some of them will require changes, some of them won't, but just wanted to make sure that everyone was aware. So in the proposed rule, or in the final rule, there were new federal standards for certain marketplace operational procedures that would require state-based marketplaces to implement new network adequacy requirements. So the rule really puts the requirement on exchanges to make sure that these network adequacy requirements are met. But it is clear from conversations with CMS that existing relationships like the one we have currently, where PID does the reviews for network adequacy and many other plan filings, would count as meeting that requirement. So we don't think that this will really mean significant changes for how Pennie does our business on the plan certification side, but we'll continue to work with PID on exploring and analyzing that new requirement. But we don't think that would fundamentally change anything about the plan reviews that are currently in place. The other item, just for awareness, is that it provides additional flexibilities for state implementation of essential health benefits. This is something that, again, overlaps with the marketplace world, but is really more of an individual market standard. So just flagging it for awareness. Again, that tends to be something that the insurance department looks at. The next item is that the final rule calls for removed administrative barriers that prevent individuals from gaining and maintaining coverage, while providing SBMs with the option to allow for retro term of QHP coverage when a consumer retroactively enrolls in Medicare Part A and B. So since the rule came out recently, we are still looking at this from a Pennie perspective. I don't think we do exactly what is in the rule at this point, so we're analyzing what that would mean to take that option, and that would be something that, based on that analysis, that we would potentially come back to discuss more. The last one is what we already discussed around requiring state-based marketplaces to pay for the income verification check through Equifax. Next slide. So one of the more significant changes, at least for Pennie specifically, is that CMS is reinstating the policy and the processes around failure to reconcile. So this is when someone receives APTC, they are required under law to report that on their taxes, so that if their income was different, that is how the reconciliation occurs. Either they get more tax credit because they overestimated their income, or they pay back some of the tax credit because they underestimated it. The rule generally is that for people who do not take that step to reconcile, they are not eligible for tax credits in the years in moving forward. So this is not this is something that was put on hold during the pandemic because of the backlogs in tax filing, but it is now in place again with a slight change, and that change is that now people who have not filed their APTC with their tax filings for 2 years, that is the time in which Pennie would be required to strip APTC moving forward. So this
Hey,
will
Devin,
be, yeah.
Can I interrupt you just for 1
Yeah.
second? Do we have any idea how many people would fall in that bucket, or would we not know that yet?
We don't at this point because it's not something that we've tracked closely in the prior years, because we have not yet had to implement this from Pennie's perspective. So other state-based exchanges who've been around longer, this is a slight variation on something they used to do. For us, it is a new implementation. So, we are working through a lot of those initial policies and procedures about how to go about doing this for the first time.
Okay, thanks.
One one of the most complicated pieces about this is that whether someone reconciled their APTC or not is considered federal tax information, which for people who are aware of that has a lot of very stringent requirements around it about who has access to that information. So for example, this can result in notices that say this may be a reason why you're not receiving tax credits anymore, or here are several reasons you might not be receiving tax credits anymore, of which this is one, to kind of shield that actual knowledge that they didn't take this action from anyone else. So call center reps, anyone helping consumers, et cetera. So it does result in a very difficult consumer experience, especially to explain why they might have lost their tax credit, which is clearly something that people would want to know about. It was a challenge when I was at healthcare.gov. It's an inherent challenge across the program, just given the sensitivity and the stringent requirements around reconciling. So just wanted to flag this as something that we are starting to implement for this open enrollment period. There will be more information that we will be able to share with all the sister networks and everyone about what that will look like from Pennie, but just flagging that it could, this could have impacts on sister networks and also insurer customer support. There could be more confusion around potential loss of APTC due to this requirement. So did want to flag that as one of the more significant changes specifically for Pennie. There's
Any
also
questions? Oh, sorry. Go ahead, Devin.
No, that was a good pause. Any questions?
Any questions on the first piece before she moves into the DACA rule? Nope. Okay.
And then, so there was a rule finalized even more recently for deferred action for childhood arrivals. So this was something that was proposed a while ago, and that modifies at a federal level the definition of lawfully present to include DACA recipients. So currently they are not eligible for marketplace coverage. They are not considered under prior rules to be part of the definition of lawfully present. However, now they will be. So that would allow them to enroll in coverage through the marketplace with the federal financial help. And that is effective for this upcoming open enrollment, November 1st, 2024. One difference in the final rule from the proposed is that it does not extend the same definitional change to Medicaid and CHIP. So, we need to work through some of the conversations there around ensuring that it is only, applied to Pennie and making sure that we have a clear consumer message for that difference between the two programs. Federal estimates are that there are about 4,000 active DACA recipients that reside in Pennsylvania. That is the total number, so we don't know how many of those actually are uninsured or would be looking for coverage. So that would be, a relatively small population, but this could potentially be a meaningful option that would be newly available to them to enroll in coverage with financial help. So we are working to implement that change as well as required under the new final rule.
Okay. Any questions on either reg for Devin? Okay, then we will move right along to talk about the Assisters Services RFP, and I think you're going to start that, Devin.
Yep, did want to start off to say that there was a request for proposal posted just this week, so it's hot off the presses. Wanted to make a note up front that rules around procurement are very rigid, so we will not actually be able to take any questions on what we're about to talk through. We wanted to provide a summary of what is in that RFP, but questions and discussion would need to go through the formal procurement processes. So we just wanted to explain that from the beginning, so we didn't just to kind of set the tone of what we'd be able to cover today. That's consistent within the rules of what we're able to talk about. So with that, I'm going to turn it over to Chachi.
And I'll just volley it right over to Anna so that she can work through the disclaimer.
Yes. Hi, good afternoon. Just a quick disclaimer before we move on. If any of the employers of the board members are interested in participating in the Assister RFP as a contractor, subcontractor, or partner, we just ask you that whenever we have future conversations about this RFP, that you recuse yourself from any discussions just to prevent any potential conflicts. Thank you.
Thanks, Anna. So yeah, I just wanted to roll through the highlights of this RFP. I feel that we've kind of clawed our way to the beginning with this, but for the initial contract year, this is going to be for 4 years with 2 optional 2-year renewals, so a possible total of 8 years. And what we're really looking for is a lead contractor that would subcontract with no less than 5 and no more than 8 regional organizations to really regionalize our outreach, our education, and enrollment. So really partnering with organizations that are entrenched in their region so that they can best serve those counties in that service area. And then those regional organizations, part of their role, they will be the main driver of that outreach, education, and enrollment. But one of the expectations from the regional organizations is to really kind of grow out their network as they're working. And we're kind of calling those partner entities. So really the primary goals are kind of fourfold here. Increase regional presence, as I mentioned, diversify the partner base, find those trusted voices, those community leaders, really targeted outreach, and then have well-defined reporting and expectations from the assister network. And if we could just jump into the next slide, it's more of an illustration of how we're seeing this play out with Pennie and the lead contractor working hand in hand and driving the strategy, and then but also having that strategy kind of come up from the regional organizations to inform it as we move forward. So if we could just dive a little bit further into the regional organizations, just so that we weren't bombarded with a full graphic on the next slide. Really these partner entities could be as small as, just hanging posters and banners or passing out information, or even a little bit more involved as we go. So, there's only 6 partner entities, 7 partner entities on this graphic, but really kind of envision that as almost like a lottery ball box. So really, really diversifying and finding partner entities throughout their work. As mentioned, I wish I could take more in-depth conversations, but the RFP process has a pretty rigid set of rules, and if we were to take any questions, then we would have to show those in the work. So just appreciate the time and all of the input from board stakeholders and our partners alike to help us kind of bring up to this point, and excited to get the process moving.
Sure. Thanks, Chachi. And I guess with the disclaimers from legal, if you have any questions, too bad, today is not the time. So appreciate that presentation and appreciate the update. Certainly we'll be interested in hearing updates to the board kind of as you're allowed to share more throughout the process and as this comes in later on. So thank you for that. So our next agenda item, I won't turn it over to Devin because it's a conversation about performance evaluation of the executive director. And for those of you that I think everyone was around when we did this. Well, maybe not everyone was around. We had done a performance review of the former executive director, and we created a personnel committee, a smaller group of the full board. I think it was probably 5 members. I think all of us are still here actually because we used that same group in kind of vetting candidates for the executive director for this time. But really, at that time, and when we had brought Devin on board, we thought that we'd come back after about a year to do an evaluation or start an evaluation process for the executive director. So now Devin has been here, I think, since March of 2023. So we're a little bit over a year at this point, and wanting to get that process started. So I think in public session, we'll hear briefly from legal and through from HR on different options that we can pursue. And then we will pick this up in executive session after this initial conversation. So Anna, Paulina, and Alana, I will turn it over to you.
Yes, thank you so much. Yes, so before an evaluation actually can take place, the board has to decide what evaluation actually is best. There are three options that the board has. The first one is a structured dynamic evaluation by a vendor. The second one is a hybrid evaluation that can be done internally. That could also be a 360, and Lainey will explain exactly what that means. And the third option is just a very basic in-house evaluation. Next slide, please. So the first option is the structured dynamic evaluation process. It is a vendor-led 360 evaluation. Lainey, can you please provide information on what a 360 evaluation is and the details of that option?
Yes, absolutely. So for any of the 360 evaluation, the review is going to consist of a survey of board members, peers, direct reports, and a self-report from the executive director on the skills and ability that the executive director possesses. There's a variable number of questions depending on the vendor on a rating scale, and that will be sent out electronically to the reviewer panel and the executive director for self-assessment. After the completion of that survey, the results are presented in a report format with feedback directly for the executive director.
Thank you. Next slide. The second option is a hybrid evaluation process, and that would be conducted internally. Lainey?
So this would be conducted in our internal Pennie HR. We had created kind of a mock 360 assessment survey through Microsoft Forms. The review of this 360 would look similar to the vendor review. It would consist of surveying that group of board members, direct reports, and peers, as well as the executive director on the executive director's prior performance in the past year. The questions can be a mix of ratings on a scale and essay questions, and the number of questions is customizable, and a report of findings can be produced. The board that can then prepare a Commonwealth standard employee performance review with ratings based on the survey data to provide the executive director with results and any other goals or objectives for the future year.
Thank you. Next, please. And the third option is just a very basic internal evaluation. Lainey?
Yeah, this is more like a cursory review done internally with the board. This would be conducting a discussion of the executive director's performance during the year through a personnel committee and HR. They may meet with the executive director, but they may not. If there is no meeting for this option, it is based on the reports during board meetings and other interactions throughout the prior year. So there would be no formal employer performance evaluation conducted.
Perfect. Thank you. So those are the three options that the board has for an evaluation process for the executive director. Thank you.
Thanks. So any questions on that brief presentation while we're in public session? When we go into executive session, the second agenda item will be kind of talking about what next steps look like and kind of the personnel side of this. But if there's any more general questions, we can address that now. Seeing none, I think it's the time in the agenda where we will go to executive session. So board members do have a second Teams link. We will drop from this link, move over to the other Teams link. And for those that are also listening to this call, we will come back because we will have a vote on kind of a sister contracts when we come back, but need to go into executive session first. So I'm not sure how long this will take. I would guess around half an hour, but you're welcome to stick around or you're welcome to leave and come back. So board members, I will see you on the other teams in a minute. All right, we are back. Couple minutes late, but we're back. And we're back for only a couple minutes. So we're back in a session, coming out of the executive session where we talked about kind of budget and other confidential matters, looking for a motion to authorize the Pennie Executive Director to execute and take the appropriate action to fund the full 2024-2025 Assister contract renewal, which includes the base contract and the expanded Assister network activities. Do we have that motion?
Yeah, this is Frank Fernandez with Capital. I move on that.
Frank moves. Do we have a second?
Colleen Kavanaugh, independent.
Colleen seconds. Any discussion? Hearing
This-
none, all in, whoops, go, I'm sorry, I cut somebody off.
This is Tia. I recuse myself from the vote.
Thank you, Tia. All in favor, say aye. Aye.
Aye.
Any opposed, same sign. Hearing none, we'll have the record reflect it was unanimous with Tia abstaining. So as next steps, Devin, we'll turn it to you to lead on the two outstanding issues. I think one would be planning our emergency board meeting in July so we could take a vote on the modeling and to continue to work on the plan simplification process. So any other business before we close? Did you have another thought, Devin? I'm sorry, you came off mute. Nope. Okay. Well, thanks for bearing with us for an extra 15 minutes. Appreciate the conversation today and hope everyone has a good weekend and we'll talk soon. So take care, everyone.
You too.
Thank you,
Thanks.
everyone.